Good afternoon, or if you're joining us from the States, as one of our colleagues is, and good morning. And thanks to everyone for joining our webinar. And today's event, we'll hear from Mr. David Galvin on the findings from the IPCOR Prostate Cancer Outcome Research Project. I hope you and loved ones are keeping well during our current challenges. And just before I kick off, I wanted to get a few housekeeping things out of the way, if that's okay. Firstly, as usual, I want to thank my team and especially Shauna, who's doing all the arranging behind the scenes. I was slagging that Shauna's a little bit like our air traffic controller, and hopefully we'll make sure that we don't crash and burn on the technology side. Regards our talk, David will speak for about 20-25 minutes or thereabouts, leaving us with some time to have a discussion and answer some questions at the end. We'd love to hear your comments and questions, so please do use, you'll see down the bottom of your screen there, the Q&A button, and you can use that throughout the talk at any stage. Just put your comments or questions in there, and then when David is finished, we'll get to as many of those points and questions as we can at the end. By all means, feel free to tweet or that, or send anything out like that. And finally, just to say, we will record the talk and make it available afterwards. So if people are agreeable to that and if people are cognizant of that. So we've two guests today that I have the pleasure of introducing. And firstly, I suppose a little bit of background. IPCOR, the Irish Prostate Cancer Outcomes Research Project, has been running now for over about 6 years. And it was only made possible with the support of our partners, Movember. So it's a very great pleasure to introduce the first of our guests today. That's my colleague, Kelly Page, who is Global Director of Clinical Quality and Survivorship at the Movember Foundation. And Kelly's going to say a few words. Kelly, a very good morning to you, and thanks so much for joining us all the way from the US today.
Thank you, Rob. It's very much a pleasure to be here and to represent Movember for the talk. And as we're addressing the Irish Prostate Cancer Outcomes Registry, I wanted to just pause and take a moment to really thank the community, the partnership with Irish Cancer Society, the clinical leadership, but really the Irish fundraisers and Movember mustache growers or those who have donated to the campaign. The Movember Foundation runs an annual campaign, of course, to grow mustaches for men's health, and it's only through the dollars that we're able to support such an impactful program and to run our prostate cancer initiatives around the world. So I wanted to start with that gratitude, because it really is the over 20,000 people last year participating, but really the hundreds of thousands in Ireland over the years that have made it possible. So thank you for that. I wanted to just take a moment to build a little bit of that international context of the Irish Prostate Cancer Outcomes Registry. And for Movember, the strategic aims in prostate cancer is really around having the number of men dying from prostate cancer, having the number of men experiencing the side effects, both mental and physical side effects from prostate cancer treatment and that diagnosis, as well as improving the quality of life. And we do that by investing in really 3 strategic pillars: the biomedical research and translational research side of things, the clinical quality initiatives, of which the Irish Prostate Cancer Outcomes Registry is a part of, a key part of nationally, as well as survivorship. So thinking about how the services and care that men are receiving, how the information they're receiving continues to help improve their quality of life throughout the prostate cancer experience, treatment and beyond. So with that, the Irish Prostate Cancer Outcomes Registry is such a key part of this work. It is definitely a model that is one that we fund and support and are promoting internationally, as well as in Ireland, and one that we will continue to learn from, to grow from, and all of this data, all of this information, as it matures and gets richer and richer, which I know David will speak to, will only make some of this more possible, to do a better job to reach more men and to really improve the care that they're receiving, and their quality of life in that journey. So thank you again. I am happy to turn it over to David, who's really going to walk us through the details. But on behalf of Movember, just can't say enough about how great it is to be here today, and also to hear and to see the outcomes of this work come full circle.
Kelly, thanks so much for those words, and wholeheartedly agree with what you're saying there, especially the support that we get from people up and down the country, which enables such really important research and making advances. So now it's time to introduce our main speaker and the head of the IPCOR project, Mr. David Galvin. Prostate cancer is our most common cancer in Ireland, with around 3,500 new cases per year. The disease is really a collection of different cancers originating in the prostate gland of men. That's where I suppose the designation and the definition comes from, but it is a collection of different diseases. There can be huge differences in outcome for men, reflecting the different presentations of the disease. And while many men, especially who are older, will present with a slower growing version of the disease and may indeed be managed by active surveillance, some men will present with more developed or more advanced or faster growing forms and will require much more involved treatment and intervention. Even in my time, research has led to a massive increase in the number of treatments available. However, relatively little research has been undertaken on the long-term experience of men and their loved ones in dealing with the cancer diagnosis and dealing with some of these newer approaches in medicine. The speciality of medicine which most deals with prostate cancer falls to a group of specialist surgeons called urologists. And it's therefore great to hear from one of our leading experts, the leading urologist country in this speciality, and that is David. David started in this area when he completed his basic surgical training in the Western Surgical Training Centre in Galway, and that was followed by 2 years of laboratory research for his MD thesis at the Mater Hospital in UCD. He completed his higher surgical training in urology and was awarded the Urology Fellowship from the Royal College of Surgeons in Ireland in June 2008. He then went to complete his fellowship in urological oncology at Memorial Sloan Kettering in New York in December 2010. He was appointed a consultant in urological oncology in Essex, in the Essex Cancer Centre, before being appointed to both the Mater and Vincent's Hospital in the Ireland East Hospital Group, funded by the National Cancer Control Programme. David is also the head of research within the Irish Society of Urology, senior lecturer in UCD, and as we'll be speaking about today, principal investigator of the Irish Prostate Cancer Outcomes Research, the IPCOR study. So David, without further ado, really grateful to you for your time today, and I'll hand it over to you.
Great, thanks Rob. I'll just share my screen. Great. You can hear me okay there, Rob? Great.
I can hear you fine, yep.
Fantastic. And thanks very much for the kind introduction. And of course, thanks to Kelly. It's wonderful to see her here with us today as well. And a special thank you for the Irish Cancer Society for hosting this afternoon's talk, and for the Movember Foundation as well, for all their support for this work. Without the combination of the Irish Cancer Society and the Movember Foundation and all the fundraisers, none of this would have been possible, and we're forever indebted to them for their support. So we've entitled the talk "What Men Want" and reflections on the IPCOR program. And I say reflections on the IPCOR program as now the funding period for this prostate cancer initiative has come to an end. We can think back about some of the successes and some of the challenges of the program and some of the early results. We very much want the IPCOR program to go on forwards into the future. And at this early stage, we're really only starting to look at the masses of data that we've accrued. And we're very hopeful over the next year or two that we'll be able to do a much more in-depth analysis of the data and see what it tells us about prostate cancer care in Ireland. But I'm hoping I can share with you some of our early thoughts and findings in the study. So I just wanted to sort of open up by just outlining a couple of key or principal points that I feel they're important about why the talk is entitled What Men Want, because I really want to say is what's important, I believe, in terms of prostate cancer care and what's important to men. And I think equality and every man having a fair crack at the whip when they're faced with a cancer diagnosis is vital. Every man wants a fair fight. And what's key in terms of making equity and the service equitable is that it shouldn't make a difference where you're from, where you live, what your social status is in life, whether or not you're from a rich part of the country, a poor part of the country, whether or not you're from deep in rural Ireland or whether from urban Ireland, every man should have the same opportunity for the same care. What every man wants is an early diagnosis, appropriate treatment, and support to return to their pre-diagnosis quality of life. At the end of the day, nothing matters to us really more so than good outcomes, and patient outcomes are vital. And what will happen is the resources will follow centres and practices that show good outcomes. So it's vital in terms of our provisioning our resources into the areas where we'll get best value, is that if we can put resources in places that have proven to show the best patient outcomes. After all, what really matters is how the patient does at the end of the day, whether in terms of cancer outcome or whether it's in terms of their quality of life and the side effects from their treatment. In order to achieve these high patient outcomes, the most important ingredient is the ability to collect high quality data. Without high quality data, we are really operating in a vacuum. We don't know what's right, what are the best outcomes, and what's the best thing to support with the finite resources of our healthcare system. When we have high quality data, this leads to transparency in healthcare decision making. For example, if one hospital is able to acquire its clinical data, as is another hospital, what tends to happen is that both the hospitals will try to develop an air of competitiveness, and that will drive standards and improvement forward in terms of prostate cancer care right across the country. Peter Drucker was a key business developer in the middle of the last century, and really, when he came up with a very popular phrase that if you can't measure it, you can't improve it. And this is really key from what all our prostate cancer data collection is all about. If you can't measure success, and if you can't measure good, high quality cancer treatment, if you can't measure outcomes, how are we supposed to change them and improve them? So that's what's key about IPCOR, is about collecting data so that we can improve services. How IPCOR works is that it receives data from a number of sources. What we do is we collect data, high quality clinical data from patient records. We also ask patients to complete patient reported outcome measurements. Ideally, we collect urine and blood samples, and we also collect socioeconomic data about the patients. And all this data is fed into the IPCOR registry, so it allows us to collect a vast range of high quality data about our patients, about their outcomes, and about prostate cancer care in Ireland. At the other end of the IPCOR registry, we have a flow of programs that flow out of this registry. And collecting this data allows us to do a large range of a number of key projects. I suppose primarily what we like to see is the generation, if you look at the graph on the left-hand side, the development of national and hospital reports. So where we can use this data to report back to the Health Service Executive, the HSE, the National Cancer Control Programme, and the Department of Health and other stakeholders. We can deliver reports about the state of prostate cancer care in Ireland. We can also deliver reports back to individual hospitals and even individual doctors about the care that they're delivering. And this ideally will drive improvements then in terms of prostate cancer care across the country. Moving up along the graph, we can also provide healthcare economics programs, research programs. So to look at if healthcare budgets are a finite resource, how do we best spend our money in order to provide the best patient outcomes for patients going forward? So healthcare economics is vital, and we plan to develop health economics programs in the future with future iterations of the IPCOR program. We also plan to provide high quality clinical data to support policymakers and healthcare providers. If we can provide high quality data to healthcare providers, they'll be able to provide resources for patients so that we can resource treatments that work for patients and provide supports to patients that really matter. In future iterations, we also plan to support a biological resource. This would be collecting urine and blood samples from patients at the time of their cancer diagnosis and throughout their treatment. And this will help guide scientists to potentially find new targets for prostate cancer treatment, but also to risk stratify patients, just to find out to better define patients who will do well with certain treatments and who need additional treatment at certain times in their care. Also, very keen to support advanced nurse practitioners and their role in prostate cancer survivorship programs, similar to what's available in certain hospitals around the country. But in my own hospital, the Mater Hospital, we have a very successful Prosper pathway, which is a program that manages patients and helps support patients at the time of their diagnosis and throughout their follow-up care. So survivorship programs are key, and we believe the IPCOR Registry can support these programs going forward. The IPCOR Registry, you can see from our links here with the Movember Foundation, is key to place Ireland central in the global fight against prostate cancer. And from our links with the Movember Foundation, we get to collaborate with a large range of institutions and collaborators around the globe, which can only help the Irish patients at the end of the day. I just wanted to give you one example of how prostate cancer services are changing in Ireland and how the IPCOR Registry has been able to demonstrate that change. From our reading of the literature, we were able to come across a paper, a publication that was made about nearly 10 years ago by authors in the National Cancer Registry. And this paper was focusing on access to prostate cancer care for patients in Ireland and prostate cancer or PSA testing. And the conclusion of that publication was that possession of private health insurance was the largest determinant of inequality among prostate cancer care. So it was suggesting that there were sharp divides between the care that was being provided within our public healthcare system and what could be provided outside of that. So we've looked at this within the IPCOR Registry. Here we have data that demonstrates every PSA value on a graph on the 6,800 men that were included in the IPCOR Registry. And you can see there's a large range of PSA values, but the vast majority of patients have PSA values ranging between 0 and 20. And the average PSA value for a man diagnosed with prostate cancer in Ireland is approximately 7.2. Examining our cohort of patients in the IPCOR group, we were able to look at the social deprivation index. And this is the classes 1 to 5 of social economic status. And you can see that between the different groups, the IPCOR population of 6,800 patients is divided evenly really between all 5 of the groups, suggesting that the IPCOR population has a good spread of different social economic classes right across the country. However, then, if you break down the PSA values and look to see how the public service compares to the private system now in Ireland, and very much thanks to the rapid access prostate clinics that have evolved, you can see that the PSA values in private patients attending versus the PSA values of men attending the rapid access clinic under the age of 70 are virtually identical, regardless of public and private access. So this suggests that right across the board, we now have a much more equitable system where patients, whether they're public and private, are accessing care at the same point. So I think we've seen quite a significant change over the last 10 years in the access to care for patients, so that patients can access care very much right across the board. So this is a significant change. We did notice that there was some increased or improved access times for patients in terms of getting time to biopsy and their information that we can improve on within our public healthcare service. So how do you go about measuring success of the IPCOR program? I think, as Kelly alluded to in her introduction, what we've seen really is a groundswell of support for the IPCOR program right across the board, from patients, from family members, and from the healthcare professions as well. We've seen engagement of urologists right across the board, scientists, radiotherapists, nurses, and medical oncologists. We had 69 medical specialists sign consent forms to include their patients in the IPCOR program. which was virtually every medical specialist in the country dealing with your prostate cancer. We've also seen the engagement of patients right across the board, where we've had patient representation on our steering committee right since the inception of the IPCOR program. And we've also had the involvement of a PPI, or a patient panel, to review our IPCOR reports. But patients too have been involved in a much wider scale. We had 1,400 patients complete our PROMS collections, and that's our patient reported outcomes measurement charts. And these were returned to us in the IPCOR program, for which we're very grateful. But there's been a widespread engagement in patients in the IPCOR program as well. Not to forget that we have established Ireland's largest disease-specific registry, which now sits and is fully accessible as the IPCOR database. We also engaged, as I said, with clinicians, but also with hospitals. This is just a picture of a plaque that I presented to Galway University Hospital on visiting the hospital there, which they were allowed to display proudly on the walls of their clinics, if should they wish. But this was in recognition of their commitment to the IPCOR program and the inclusion of the data from the Galway hospitals. And we were able to visit Galway Hospital and present the data back to them. And we hope to engage more with clinicians in the future. We were also able to produce a very in-depth clinical report in 2018, which included a large amount of clinical data, much of which had never been seen before in Ireland. And on our further analysis throughout the next 12 to 24 months, we'll be updating this report with a further in-depth analysis. Some of the data that we were able to obtain from that report, I was going to share with you at this stage, and largely because some of this new data was able to change the way we look at prostate cancer in Ireland across all our cancer centres. Well, firstly, just looking at the age at which patients are diagnosed with prostate cancer in Ireland, historically, data from the National Cancer Registry had shown that the average age of diagnosis in Ireland was approximately 72 years of age. But when we're looking at our more recent data, we were able to show that in 2018, the average age of diagnosis has actually decreased to closer to 65 years of age. And I think this really represents a very significant, what we call in medicine, a stage shift. Detect prostate cancer at an earlier stage in patients. And this, I think, is largely due to the establishment of the rapid access clinics, because as we all know, if you can detect cancer at an earlier stage, you're more likely to be able to effect a cure. The success of the rapid access centres can be seen in this graph. This graph shows the proportion of men at different age groups. Those who chose to attend publicly in the rapid access clinics are in the lighter blue, and the darker blue represents the private hospital system. So when you consider that about 45% of the population have private healthcare insurance, you're able to show that at every age group, most men chose to attend our National Cancer Control rapid access clinics or the urology clinics. You can see there's a slight rise over the age of 70 when men who no longer meet the criteria for the rapid access clinics probably choose to access care in the private system. But I think this graph at all age groups shows the success that we've had in the rapid access system and the engagement with GPs and primary care in referring patients in. This next graph really shows the change in diagnosis and the effect that PSA has had in diagnosing patients with prostate cancer. PSA testing is now undoubtedly the driving force in the diagnosis of prostate cancer across the country. We found that over 80% of men had no symptoms in relation to their prostate cancer and were diagnosed with PSA alone. However, you can see there as men age, there is a slight increase in the number of men presenting with symptoms related to their prostate cancer and a reduction in the number of asymptomatic men. So we believe strongly that men should be seeking out to have their PSA checked, particularly from the age of 45 onwards. We were also able to examine the range of Gleason score. So Gleason score is the grading system we use in prostate cancer, and we can tell this from a patient's biopsy. The higher the Gleason score, the higher the reading would suggest the more active or the more aggressive prostate cancer being present. As you can see here, under the age of 65, the vast majority of patients have a much lower Gleason score. some 70 to 80% of patients would have a Gleason score 6 to 7. And these are very favorable diseases. And the vast majority of these patients you would expect with this type of grade of disease would have highly curable prostate cancer. You can see then as men age, there is an increasing grade of disease and a reduction in the less or more favorable prostate cancers. And that's largely because we generally don't biopsy men as much as they get older in order to avoid picking up milder prostate cancer. Also, the introduction of MRI scanning, which has been widespread over the last 10 years, means that we can filter patients out who are unlikely to have prostate cancer on their biopsies. And this is very useful in reducing the incidence of prostate cancer unnecessarily as men get older. There is a scoring system we use called the CAPRA score. And what CAPRA does, it's a useful tool in evaluating the outcome of patients in relation to prostate cancer care across the country. So for every individual patient in Ireland, we can combine their age, their PSA value, their Gleason score, and their clinical stage. And this will allow us to give a single score to every man called the CAPRA score. And we can chart this, as you can see in this image here. The CAPRA score can be used to subsequently assess the outcomes of patients. If a patient has a low CAPRA score, it would suggest that his risk or his prognosis from prostate cancer is excellent. And you'd expect those patients to have very good outcomes and do very well. Whereas patients with higher CAPRA scores are more likely maybe to have recurrent disease and have more need for treatment, and that may be reflected in terms of their quality of life and some of their outcomes. So using this score, we'll be able to evaluate what patients have good outcomes, what patients would expect to have bad outcomes, and then whether or not the patient's outcome scores, the PROM scores, reflect these. So this is a very useful tool, and we'll be using this in future iterations of the IPCOR program. So what do we learn from the challenges of the IPCOR 1 program? Well, I think one of the most important things is that as investigators, we found that it's essential that we must control the data. Due to a number of issues, it proved very difficult for us to access the data that we were collecting. And as a result, some of our aspirations, unfortunately, were not realized during the IPCOR program, and largely due to difficulties with data access. So future projects that will involve IPCOR researchers, we will ensure that we have full control of our data so that the project can reach its full potential. It's also important to engage patients more meaningfully and in greater numbers. And we've also learned that it's important to engage with patients face-to-face. Particularly in the IPCOR program, we had used postal questionnaires in order to send out PROMs and access consent for patients. Whereas in the future, we would hope that a face-to-face program where we engage directly with patients in clinics will allow us to reach our goals better. I think in fairness, we underestimated how tough this project was going to be. Whenever something has been done for the first time, as this was in Ireland, it's always hard, and we encountered many challenges along the way, but we learned from them all. In future iterations, we hope to broaden our engagement with clinicians, with the nursing establishment, with stakeholders and patients moving forward. And I think certainly we've learned a lot of lessons from the IPCOR program to date. I want you to just show you a further example of how the IPCOR data can be used to support healthcare services in Ireland. We've been involved in the NCCP and the National Cancer Control Programme, and the Department of Health issued the National Cancer Strategy for 2017 to 2026. And recommendation for this National Cancer Strategy is that we will develop national prostate cancer guidelines, and the National NCCP are asked to perform regular audits on the implementation of our national guidelines. For example, here is IPCOR data supporting NCCP audits potentially. For example, the use of bone scanning and the use of CT scanning are laid out in our national guidelines and are important to use in specific situations. If we examine the IPCOR data, we can see here how we can see in real time the implementation of national prostate cancer guidelines. We've outlined here using again the CAPRA score, suggesting increasing risk of prostate cancer. And you can see how this reflects increasing staging scans. So as somebody's risk of prostate cancer increases, doctors are ordering more CT scans and bone scans according to the aggressiveness of the disease. And this is very much in keeping with our national prostate cancer guidelines. So on an ongoing basis, this sort of activity can be monitored, and we can see the implementation of national prostate cancer guidelines in real time. We've also examined aspects of geographical differences in access to care. As I said at the outset, we feel it's very important that no matter where anybody lives in Ireland, they should be able to access the same degree of care at the same time. Cancer care in Ireland is now provided in cancer centres, which are obviously means centralisation of care, which can mean further distances for patients to travel. Very much grateful to the National Cancer Registry, which using their geocoding tools, we were able to measure the road distance for every IPCOR patient to his diagnosing hospital. This data has never been examined before in Ireland. In addition, men often consider transport and distance in their treatment decisions, and we want to look at these in more detail. This graph, you can see it demonstrates the range of counties in Ireland, and you can see the distance travelled by the patients in each of the counties. The average distance of travelling to a diagnostic hospital in Ireland was 39 kilometres, and you can see here how Cork, Dublin, and Galway all have very favourable distances to reach to the local hospital. But you can see as the counties get more rural, there's an ever increasing distance for patients to travel. Patients obviously from Donegal are particularly hard hit, with the average patient nearly traveling over 200 kilometres in order to access care. And you can imagine how this might influence patients' treatment decisions, but would also have repercussions for family members and so on. So moving forward from IPCOR 1, we are bringing together proposals for what we are describing as IPCOR 2 and a wider program known as iProstate. Right now, the IPCOR database is located on a secure server in UCD and is available for research. And we would encourage people who want to access the database for the purposes of research, they can apply through the IPCOR website, and we will review the application before allowing access to the data. We are bringing forward a proposal for a dedicated IPCOR researcher so that the data that has now been collected can be reached its full potential. We have significant plans for the IPCOR data and feel that a lot more research needs to be done on it, and hopefully it'll reach its full potential. As I mentioned earlier, our vision for IPCOR 2 will link clinic patients with global databases and access to online support tools. We also have an iProstate proposal, which places the IPCOR registry at its very core. But as I showed in my earlier graph, this can feed into a lot of other programs, such as economic analysis, risk stratification, and the training of future scientists, which we feel is highly important. Finishing up, I just want to acknowledge the support of the Movember Foundation and the Irish Cancer Society in the work of IPCOR. I want to sincerely acknowledge all our IPCOR patients and our men who have contributed their data to the IPCOR program, the patients who so bravely put themselves forward to be panel members in our PPI groups. I also want to acknowledge the support from Men Against Cancer and the Art Cancer Support Centres who have continued to support the IPCOR program. The team at the Clinical Research Development Ireland who were so supportive. Anya Murphy has been our project manager from the very inception of the IPCOR program, and Cara Dooley, who is our statistician, who has worked so hard to provide the data that I've showed you today. Mairead, Suzanne, Michael Farrelly and Seamus and all the staff at the CRDI. I also want to thank the staff in the National Cancer Registry, the director, Kerry Clough-Gore, and Conan Donnelly, the head of research there, and all the staff and the registry data collectors who helped us obtain and bring all together all this information, but also all the nurses, doctors, and scientists who have supported IPCOR. I'll finish with that, and I'd be delighted to take any questions.
Great. Thanks very much, David. And Shauna, you might put on the cameras there for Kelly, David, and myself, if that's okay. David, thanks so much for that. By its nature, it's a whistle-stop tour of what was a much, much larger and involved project. I mean, having 6,800 men, for example, I think people can appreciate the enormity and scale of something like that. We have a couple of questions. We'll spend we've about 10 minutes to spend on questions, if that's okay. So we've a few already in and that. Some of the ones that we've gotten in, I suppose, are quite specific and treatment questions. And I suppose we also have a couple of more general ones. So first one is from John. So John wants to hear, who says the panel's view, but I think you're probably the most qualified amongst Kelly and myself anyway, on age profiling in prostate cancer. He was diagnosed in his mid-40s with stage 4 with advanced prostate cancer. And his GP felt that it was prostatitis, despite John, I suppose, now knowing that he had the symptoms of advanced prostate cancer, and ultimately John went abroad. What's your view, I guess, on the impact of age? I'm not fully sure what John means by age profiling, but perhaps he means, I suppose, around, say, screening or looking for it, or whether maybe the GP and medical community is attentive to earlier presentation of the illness.
Yeah, Rob, thanks. So I guess if you think about some of the data that I showed there, historically, we've associated prostate cancer as being a disease of old men. And that sort of, that I think that needs to change. I think we've shown there with the IPCOR data, the average age is getting younger and younger with men. It's not because the cancer biology or the disease is changing. It's because we're detecting it earlier. What we hope is a much more curable stage. So we may see the mean age drift down earlier. What I didn't show there was that under the age of 50, only about 3% of men with prostate cancer in Ireland are diagnosed under the age of 50. So I suppose as a nation or as a health service, we have to be conscious that it is very uncommon, not exactly rare, but it is uncommon for men in their 40s to be diagnosed with prostate cancer, and therefore in creating guidelines and so on, we have to be cognizant of when disease is most likely to strike patients. As you know, there's certainly a changing field in terms of PSA testing. There is a consensus now that seems to be gathering a lot more evidence that men should be getting a baseline PSA around the age of 45, and using that PSA value to guide whether or not they need more regular follow-up, or whether they can be a little bit looser with less regular follow-up. And certainly patients with high risk features such as a first degree family member and so on or Afro-Caribbean gentlemen need to get their PSA checked from the age of 40 onwards. So those sort of high risk individuals. I suppose specific to John's case, as you mentioned, he must have presented with a lot of urinary symptoms, and at the time, and in a man in his 40s, clearly those symptoms are most likely going to be down to prostatitis. In the vast majority of patients, as I said, a prostate cancer diagnosis at that age group would be exceedingly rare.
Okay, but perhaps there's some onus on us, I guess, to ensure that the wider healthcare community recognizes that it is a possibility, and to certainly include it in the thoughts, even though it may be a low probability. Kelly, would that be the experience, I guess, globally? That sort of age disparity and those sorts of views that it is a disease of older men, while actually the biology reflects something quite different.
Yes, if I could reflect on the international conversation, which has a lot of similarities here. I think as we are seeing the diagnosis improve earlier. There's certainly shifts. However, with some of the confusion and the rollout of PSA recommendations, and that's true in the United States, but also in other countries as well, we're finding that disconnect between primary care, specialty care, and men themselves, and how they can be an advocate for their health and for what's happening for them. So a lot of our messaging very much is around the conversations, of having those conversations with your doctor, knowing the family history and also some other risk factors that go into that, and hopefully to see that get clearer with the recommendations of how men can get PSA tests and continue having those discussions. And it's to hear when that is happening and that's not being received. But I think that's where we need to continue to think about how we work from both angles from a diagnosis perspective.
Okay, thanks, Kelly, and John. John is grateful for the answer there. Another question from Kevin, and I suppose it goes to the heart of one of the perceptional challenges, I think, in the two different primary streams of cancer treatment for prostate cancer. And Kevin asks about SBRT, which is a form of radiotherapy, and why isn't that more available, given the balance, I guess, of side effects and that. And I suppose perhaps, David, you're actually well set to answer that, because I've certainly spoken to a lot of men about prostate cancer, and a lot of professionals, and sometimes one profession can have a leaning towards one form of treatment versus another, and that's perhaps part of the value of the IPCOR, showing the longer term outcome for men, particularly younger men, if they choose, say, radiotherapy versus surgery or vice versa, and as Kevin points out, whether it's available to them or not.
Yeah, no, I mean, that's why the PROMS component that Movember have so strongly supported in the IPCOR program and in all their global registries is key. Is we need to hear from men. We need to hear their stories. We need them to report back on their PROMs, and it's through that we can analyze then what are the treatments that have the best side effects that preserve quality of life for patients. So we're very keen that that as many men as possible, it'll become almost standard for patients to complete PROMs, so that they'll be able to fill us in and let us know, because it's about if people don't give their experience now, how are men in 5 and 10 years going to learn? I mean, if a man is diagnosed with prostate cancer now, he could really benefit from being able to look back at patients who were diagnosed 5 years before him and be able to see where they are now and what their experiences are. And I think very reassuring for someone who's facing a prostate cancer diagnosis to realize that the vast majority of patients 5 years later are perfectly well, are doing fine and enjoying life. And if they can get that information from PROMs that men complete, that must be hugely reassuring to a man who's having a recent diagnosis. So I think that the ability to choose between therapies and treatments will I think the PROMs is central to that and supporting men in their decision.
Kevin just mentions further that he was one of those kind of 3% that you mentioned. He was diagnosed in his early 40s, and I presume by some form of PSA test or whatever, because he had no symptoms. And I suppose this is part of the conundrum, I think, within PSA. We can look at it at a population, or within prostate cancer, we can look at it at a population level and see, what age groups are most common and what age groups will run the risk of overtreatment and stuff like that. But there will always be people, men at different ages, younger ages, that present maybe without a family history or without symptoms or whatever. Is that an ongoing challenge?
Absolutely. I think, if you're in primary care as a GP, I suppose, and sometimes prostate cancer mightn't be on your radar, because I suppose, at least we have the rapid access clinics there, because that will support GPs really. If a GP has any concerns about a patient, he knows that he can get a a consultant's opinion. Ideally, we try to operate within a 4-week window so that we can see patients, whether it's an abnormal examination or abnormal PSA. If a GP has any concerns, he can get patients in very quickly, and I think that's largely to support primary care, and I think that's been really, really effective, as you can see from the data that we showed.
So one final question I might ask of both of you, but maybe David first, would be around the impact of COVID at the minute, and what you're seeing, how that's impacting, in the quality of survival, the quality after treatment, waiting lists, those kinds of things. So I suppose I asked that of David, maybe globally. Then Kelly, you might come in after that with what you're picking up from a global perspective.
Thanks, Rob. We've the way it's affected services has been fairly significant. A lot of our diagnostic services were kind of paused as COVID broke. The whole idea of we rely heavily on scans like MRI scans, prostate biopsies, and those sort of services really had to be on hold for a number of months last year. So undoubtedly that has affected the care, but we're glad to report that things seem to be getting back up and running again now. And so services are back up and running, and we're hoping it won't impact on patients hugely. We've been there all the time, and we've tried to keep the services running as best as we can.
Kelly, have you any kind of global insight on that impact, and I suppose particularly on the survivorship area, how men are feeling globally, whether there's been an impact in that quality of survivorship?
Sure. And I think the one of the sad truths is that it will take us some time to really see, both clinically and in feedback and quality of life data and information coming in from a population level, how it has impacted men and this community globally and locally. So we're certainly, that is something we want to make sure that we're capturing, and really the experiences of men. We, in a broad context, not just specific to prostate cancer, but certainly relatable, have been hearing a lot about just the isolation, the uncertainty, the increased anxieties, of course, in a cancer context, which I think is consistent with what a lot of us would expect. And with that, I think navigating with the health systems, with care teams to best support men is something, of course, that we care a lot about. And I think, as David mentioned, seeing things coming back online and really getting workflows so that patients can be seen and have the follow-up that they need. I think the silver lining, actually, that I would say that we see globally, and it's certainly still happening, is a rapid acceleration in how we can support survivorship through telehealth, by phone, and also virtually, so online, on smartphones, et cetera. And that there has really been, from a health systems perspective, a rapid acceleration of where that's acceptable and how that can be done. And if we can partner and be really smart about how to stay on that wave and use that and find accessible and impactful ways to reach the prostate cancer population and those experiencing prostate cancer to provide better support, we certainly want to do that. And our True North, a program that Movember has funded for many years in different ways, was looking at that and evaluating how to do that impactfully online and by phone. So I think for us, there is an opportunity to fill and to keep pursuing on how to do that best online. I'll say that also acknowledging, though, that we need to do it in a really smart way, where we understand some of those access challenges and who we're not reaching. And I know that care teams and health systems are also trying to think about that as well. So COVID has certainly changed the landscape and challenged us all, but it is also, I think, bringing a lot of really smart people in a multidisciplinary way together, and in some cases leveraging technology to think about how we can improve.
Thanks for that, Kelly. If it's all right, I might ask one other question, because it's from a good friend of ours, from Tom, and we may be able to get a fairly quick answer from David on this. So Tom asks, are there any new developments in diagnostic tests for prostate cancer, given the unreliability of PSA testing and reluctance of some GPs to test men without symptoms?
Thanks, Tom. We know Tom well, so it's good to hear from him. In developments, well, I think our experience is that widespread PSA testing is certainly taking place. There's obviously slow adopters that will always be out there as well, but hopefully, I think a lot of the maybe the younger GPs and so on are embracing it. Obviously, we're reliant on MRI scanning more and more, and access to MRI scanning seems to be getting better right across the country, which is vital in the diagnosis and targeting of prostate cancers. In terms of actual biologically what's available, we do unfortunately have to rely on PSA from what I can tell for the short term. There are additional kits that Tom might be familiar with, but we did try to introduce a improved test called the 4K score some time ago, and there's various others available out there, but none of them unfortunately seem to be able to surpass PSA at the moment, and the accessibility and and I suppose the fact that PSA testing is relatively cheap right across the board, it does seem to filter out patients. But more and more we are reluctant to biopsy patients without an MRI scan. So this means that PSA testing and abnormal PSAs doesn't automatically mean invasive tests for everybody, which it might have done in the past. The fact that it might mean a scan first is much more reassuring to patients and is less invasive and provides us with a lot more information than the biopsy necessarily would. So so service is improving, but unfortunately we're stuck with PSA for the time being.
Kelly, did you want to come in on that as well?
I think David has really covered it. You know, I think around the world we're seeing how improved imaging and more affordable imaging is also really helping. But still that reliance on the PSA, taking a look at, and earlier David had mentioned too, getting that earlier baseline so that men can have an understanding of how what is normal for them and how things are tracking in what would be presumed as a younger and healthier state. And I think that it's really an emerging field, and one unfortunately that isn't having kind of some silver bullet changes and dramatic and quick updates, but how we can continue to drive better diagnostics and think about the utilization of the PSA in smarter ways to reduce the biopsy burden and risks, and also make sure that we're detecting men as soon as we can.
Okay, that's a good point to make. And yeah, I mean, there's a lot more, I think, and I know Movember invests in this globally as well, a lot more to understand the basic biology as well, and try and find something that's found with a close to 100% prevalence. PSA is significantly less than 100%. So unfortunately, one can have the situation where one either has a positive PSA test, but it's not cancer, because other things can cause leakage of PSA into the bloodstream. And unfortunately as well, one can have prostate cancer without significant elevation in PSA as well. So hence why the science and the need for discussion, as David and Kelly have outlined. So okay, I think we've used up all of our time now. I just want to again express my appreciation to Kelly and David for speaking today. And for outlining the great work. I'd like to echo David's thanks. I think it's an incredible feat to all of the healthcare professionals that supported IPCOR, and the 6,800, nearly 7,000 men who contributed to the research. And I think it's really an illustration of how we can all work together, patients and healthcare professionals, to identify the challenges that are emerging. This landscape is not fixed, so we do need to continue to do that. And hopefully you found it interesting. So thanks again to our guest speakers, and look forward to speaking to folks at our next webinar. Thank you very much.
Thanks, Rob.
Thank you, everyone.
All the best.